afternoon, everybody. I am going to present a case of a 60-year-old lady who is housewife by occupation, and she is resident of Purnia, Bihar, and she presented in IOPD with complaint of diminution of vision in right eye for last 1 month with no history of any systemic complaints, for which she was started on oral steroid elsewhere. Following which her vision improved, but she came to our IOPD for withdrawal of her oral medications. On examination, anterior segment was within normal limit. There were no signs of anterior chamber inflammation, and on going to posterior segment, grade 1 vitritis was present in right eye only. Left eye was perfectly clear. Then we went ahead with fundus photo, and her best corrective visual acuity in right eye was 4/60, and left eye it was 6/9. And on fundus photo we can see there is right eye with blurring of disc margins, and bright red oranges fundus is seen in right eye, but left eye was absolutely normal. So when we went ahead with OCT, where we found loculated subretinal fluid and neurosensory detachment in right eye, whereas left eye OCT was also normal. Further, we went ahead with fundus fluorescein angiography, and we could see here multiple pinpoint leakages, and disc leakage was also seen. So we made a provisional diagnosis of probable Vogt-Koyanagi-Harada disease because there were no systemic symptoms with the patient. She only had ocular disease. Further investigation, we to rule out any infectious cause of uveitis, we went for CBC, CRP, which were within normal limit, and ESR was also normal. And systemic investigation was negative for VDRL, HIV 1 and 2. And to rule out TB, we went for Mantoux, which was 6 mm, and chest X-ray PAV was also within normal limit. To get rid of oral medications, we planned for suprachoroidal injection of low dose, that is 2 mg per 0.05 ml triamcinolone acetonide. Facial microneedle with a 30 gauge 0.9 mm tip length was used to assess the suprachoroidal space. At presentation, when she came, right eye visual acuity was 4/60, and post suprachoroidal triamcinolone, her best corrective visual acuity at 4 weeks was around 6/60, and at 12 week, the lower diagram, this is of 12-week presentation, and her vision was around 6/9 in right eye. Coming to discussion, Vogt-Koyanagi-Harada disease, it is a rare disorder of unknown origin and is thought to be an immune response to human leukocyte antigen. And typical clinical features are of VKH are bilateral panuveitis associated with exudative retinal detachment, meningismus associated with headache, and pleocytosis of cerebrospinal fluid. Tinnitus or hearing loss, cutaneous changes, we see vitiligo, alopecia. The extraocular features are rarely seen during the initial presentation, and clinical features vary depending upon the stage of the disease. There are 4 stages. We have prodromal phase, acute uveitic phase, where we see bilateral granulomatous anterior and multifocal posterior uveitis with diffuse choroidal infiltration. There can be vitritis, papillitis, and exudative retinal detachment. In convalescent phase, there is localized dermatological signs like alopecia, poliosis, vitiligo. And chronic recurrent phase, there is exacerbation of anterior uveitis, and posterior uveitis recurrence is quite rare. Prognosis is variable and is partly dependent on achieving control in the early stages with medical treatment. The diagnostic criteria for VKH disease include inflammation of both eyes, maybe asymmetrical involvement. There should be no evidence of other ocular disease in causing the inflammation, and no history of trauma or ocular surgery. There are 3 categories of the disease: complete VKH, where we have diffuse choroiditis involving both eyes with serous RD along with neurological and dermatological signs. Incomplete, there can be involvement of eye, but neurological or dermatological signs, either one of them has to be present. And in probable VKH, which I think was my case, similar eye disease features may be there, but without neurological or dermatological sign. Early and aggressive use of high-dose systemic corticosteroid is the treatment of choice, as the systemic use of steroid has their own complications. So we switched for suprachoroidal drug administration, and it has following advantages. They overcome this systemic complication, and they have targeted drug delivery to the choroid and ensures a greater bioavailability. Suprachoroidal triamcinolone injection was efficacious in reducing central macular thickness in macular edema and improving best corrective visual acuity, as was seen in dogwood and peachy tree trial in non-infectious uveitis, but no The patient was injected with single low-dose suprachoroidal triamcinolone acetonide, and following changes were associated with this: significantly reduced SRF, significant gain in mean visual acuity, there was decrease in vitritis and disc hyperemia, and there were no associated local side effects, including glaucoma, cataract, or endophthalmitis. Thank you.
Your patient has got other eye normal.
So she was diagnosed somewhere else. She came after 1 month of taking treatment. Maybe it might be subclinical in the left eye, which got resolved with the systemic steroid which she took, sir. When she came to us, she was already on steroids, sir.
You have done ultrasound both eyes?
Yes, sir. There was choroidal thickening in right eye, sir. I didn't.
Left eye?
Left eye was normal, sir. There was no choroidal thickening.
When there is a unilateral, though it's not a posterior scleritis,
yes, sir.
So unilateral secondary retinal detachment, one should keep the possibility of the posterior scleritis. So the
yes,
fluorescent angiogram, of course, is characteristic of pinpoint leak with pulling of the dye,
yes,
is suggestive of BKH. BKH is a systemic disease. So unless steroid is contraindicated or immunosuppressive agents is contraindicated, it's always to be given. Local treatment is often not, can give long-term control of the disease.
Yes. Till 6 months he was on follow-up, sir, and she was absolutely fine, sir. Till 6 months he was there.
Yeah, even with the local ocular therapy, why did you choose suprachoroidal injection? Because that is quite a blind procedure.
Yes, sir.
And
because
can have lots of other complications. So you have other options available of a local
yes, sir.
treatment.
We do have posterior subtenon and intravitreal, but sir, as this is a disease of mostly it involves choroid, so we opted for suprachoroidal injection, sir.
But they respond pretty well to intraocular, intravitreal
yes,
dexamethasone in case the steroids are contraindicated. And as sir pointed out, what were your differentials when the patient came to you? Because I know it could be asymmetrical by definition, it is
yes,
bilateral, it could be
yes,
asymmetrical. But even after 3 months or something, when you have shown the last photograph, the left eye still looked absolutely fine.
Fine, yes, sir.
And you did not give anything for the left eye.
No, sir, we didn't.
Was she on oral steroids even after you gave the local?
Yes, sir. We tapered steroid. We didn't stop it. She was on 60 mg when she came. So weekly tapering, we did 60-40 like that. 10 mg we tapered every week. And
how long did you use the steroids for?
Sir, she was on 60 when she came. We reduced to 50, 40, 30 like that.
Weekly, but for
yes,
how
sir.
long did you continue the oral steroids?
She was there, sir. In spite of giving triamcinolone, she was on steroid also, sir.
So how long do you plan to continue her on steroids? What will be your end point of treatment?
Sir, after, it is a recurrent disease. So she was on steroids, sir. 10 mg she was still taking after 6 months of follow-up, sir.
And so how would you follow up? When will you decide, or how will you decide that, okay, we can stop the treatment now? How will you follow up the patient?
So till 6 months we followed, sir. She was there.
Yeah, but what investigative tool would you take advantage
yes.
of?
Sir, OCT.
Ipsos OCT.
Yes, sir. Ipsos OCT, yes.
Where you can measure the choroidal thickening.
Yes, sir.
And still I suspect that you were dealing with the case of posterior scleritis. Because unilateral BKS, though there are
it's very rare, sir.
No,
yes, sir.
there is literature, but still I will suspect that it's a case of posterior scleritis. Second thing, that the patient came to you for removing the steroids, but still, even after injecting that suprachoroidal, you are putting your patient on oral steroids. And Walk-Owen-Hara disease, still if you are thinking that it's a unilateral BKH, then the pathophysiology behind BKH is that there are antibodies which are directed against melanin and
yes,
retinal S antigen. So steroid is not going to help you. Here actually comes the role of cyclosporin, that is a T cell inhibitor, because the entire pathophysiology, why this alopecia is happening, why this hearing loss is happening, because organ of corti is having melanin, meninges is having melanin. So all that neurological manifestations or otological manifestations, they are occurring because of the pigment, and those antibodies are still there.
Yes,
so in the management of VKH, I think the role of immunosuppressive agent is very, very important, and you will have to put your patient at least for 2 years on immunosuppressive agents.
Yes, sir.
Yeah.
One more thing, can you go back to the fundus fluorescein angiography? Yeah. So if we see, sir, right eye has a florid manifestations, but left eye has some disc staining and some staining just near to the fovea. Yes. So this could be a bilateral case of VKH.
But she was already on treatment, ma'am. Yes, ma'am.
And since the patient came to you for a tapering to take off the steroids, you should have started, like sir said, you should have started early immunosuppressant. And you cannot just attribute the role of SCTA in this case to reduce the, because the left eye has already responded to the corticosteroids.
Yes, ma'am.
Right? I think it is a bilateral case, it's not a unilateral case, because the left eye FFA has
disc
changes
there.
and extra fovea. Yeah.
And one more thing, that this early pinpoint leakage along with the pooling of the dye in the late stage with disc staining in the late stage, that can be seen in posterior scleritis, VKH and SO. There are three conditions only.
Yes, sir.
If there is a history of trauma root, then it is
SO was, yes, sir.
history of trauma, it is VKH,
Yes, sir.
unilateral involvement, think of posterior
Scleritis. Yes, sir. But we could see few changes, sir. So we thought, as he was already on steroid, it could have resolved in left eye, sir.
I think it is better that you will start either azathioprine or cyclosporine.
Immunosuppressant.
Something you will have to start.
Yes, sir.
Otherwise, the recurrences will be there and the patient will come again and again.
Yes, sir. Sure, sir.